We have been programmed to think of all inflammation as bad. And it's true, right? If you have a flat immune response to injury, you tend to chronify. So we've kind of demonized the neutrophil in all of our therapies. Regenerative therapy is kind of like a workout. You've got to suffer a little bit to get a good result at the end.
Welcome to Conversations in Regenerative Medicine. I'm so excited that everybody is joining us for a great time with Dr. Thomas Buchheit. So happy to have you here. I'll do a little introduction. But what we're talking about is we're talking about regenerative medicine and talking a little bit more about the controversial topics and talking about cutting edge insights that are shaping the future of interventional orthobiologics. And I really am excited to bring to you today Dr. Thomas Buchheit. I might have needed two H's, not two C's, but that's okay. It's Buchheit, founder of Triangle Regenerative Medicine and Biologics in Chapel Hill, and former director of the Regenerative Pain Therapies program at Duke, as well as a pain medicine physician at Duke University, Department of Anesthesiology, division chief, editorial board of pain medicine, and he is fascinated with the neuroimmune mechanisms driving chronic MSK and nerve pain. So for those of you who don't know who I am, I'm Dr. Ariana DeMers. I'm a board certified fellowship trained orthopedic sports medicine surgeon and regenerative medicine aficionado. I am a sought after educator and trainer in both ultrasound and orthobiologics, and I've successfully been able to move my practice away from insurance-based care even in rural California. So definitely can be done, and do mostly regenerative orthobiologic therapy treatments for cash-based services in my practice. My most important thing is that I am passionate about helping physicians incorporate orthobiologics into their practices seamlessly. So we're gonna get started, and there's all sorts of fun stuff. These AI companions are massively fun. I have like a billion of them myself, but super interesting. They keep asking me all these things that they want me to do, so I'm getting bossed around by these AI things. Okay, so we're gonna start with this conversation, and really, we get to hear from internationally renowned experts in regenerative medicine. We get to explore controversial topics that maybe people don't talk about on the podium. And so I really love to have more of a fireside chat conversation about my favorite topic, which is regenerative medicine and orthobiologics, and maybe gain some actionable insights that you can implement in your practice starting today. So we will get started, and I'm going to talk a little bit about my perspective on orthobiologic treatments. So my thought and my opinion is that orthobiologic treatments will be first-line treatment for musculoskeletal care in the next 5 years. The train is leaving the station, and if you are not actively offering these treatments to your patients, you gotta get on the train because it is leaving the station. Now, successful integration is sometimes difficult. I hear this all the time. We know orthobiologics is the best treatment for our patients, but how to be successful? So maybe you've tried some things, but you don't know the latest science, you don't know the techniques, maybe you're a little bit behind on ultrasound training, maybe this cash business thing is really daunting. You hear about marketing, you hear about sales, and you want to run the other way, and it's not your fault. Maybe you just thought that I'm just not good at this business thing, but clearly we didn't learn this in school. So it is not your fault. You know, some people are just struggling on the fact that they know how to do this. They know this is the right thing, but how do you actually capitalize on this $4 billion orthobiologics market out there. Yes, $4 billion. And maybe some of us are thinking, man, I deserve more, but this is so hard. Why is it so hard? So how do we win? Now, we are going to be talking about the science today. Man, we are going to go deep with Dr. Buchheit in the science today, but we also need to consider how we talk about this with our patients so we all win. And while we need a system to make sure that we hit all the high points, we're not obviously going to go over all of this today, but we are going to get a little further along the journey to be wildly successful in your orthobiologics practice. And we need a system. So to start, we're going to start with that orthobiologics knowledge. So Dr. Buchheit, why don't we get down to business?
Sounds great.
My friend, we have questions. We are wondering a lot about you, and I've read your book, and we'll go over your book a little bit more, but man, this book of yours has opened up Pandora's box. And I think that we would love to know how that mind of yours works. So my first question is, in your book, when you say immune stimulation, what does that mean in a clinically useful way, and not just biologic theory, of how is it different from inflammation? Like, we're using orthobiologics to stimulate our immune system, which is a new kind of concept that I haven't really thought about before. So can you kind of help me understand how this new...
Yeah, it's a fantastic question. I could summarize it by saying that when I talk about immune stimulation, I'm talking about good inflammation. Full stop. We have been programmed to think of all inflammation as bad. And it's true, right? Chronic inflammation, it's universally bad for us. It destroys tissues, it causes chronic pain. And because of that, I think we've all equated acute inflammatory changes to chronic. And it's just not true. If you think of good inflammation, what do we do when we exercise? You create inflammation, there's a recovery cycle, inflammation recovery grows stronger. What happens when we have a cut or a wound or a fracture? It's good inflammation. You recruit the immune cells to the area and it starts a healing cascade. And what I wanted to do in the book was kind of look at the entire field of orthobiologics and regenerative medicine simply within the immune cascade, within this cascade of good inflammation. It's confusing to, especially to the lay audience, right? When we talk about inflammation, because they've heard for so many decades that the inflammation is bad for us. And so that's why I tried to kind of change the language a little bit to talk about, it's really about immune stimulation. So those are really I almost use those synonymously, if that makes a bit of sense.
Yeah, awesome. So this is your way of clarifying the difference between acute inflammation, which we all need and want to have this healing response, versus chronic inflammation. Is that correct?
Right. Yeah. And if we look at that paradigm of good inflammation being acute, strong, short-term, and able to flip an immune switch, everything starts to fall into place and make sense. It makes sense why exercise is good for us. It makes sense how we heal. And it also explains some of these things we've seen where there's been an increasing press on the challenges and the problems with recurrent steroid injections, with chronic anti-inflammatories. And that all makes sense because those are shutting down these therapeutic responses that our bodies normally do. I mean, we have these built-in healing systems that all mammals on this earth have, and we're shutting them down, frequently. And so the focus of the book was, how do we not do that, and how do we really harness these inflammatory pathways, harness this immune stimulation, and then how does this reflect in regenerative therapies? I think PRP is a great example. You can even look at mesenchymal cell therapies and everything else. They're really just turning on different parts. But if you look at PRP, well, let's go back and look at maybe what happens if we sprain an ankle. You sprain an ankle, you bleed, you release platelets, you release these growth factors, it pulls in white blood cells, and the first white blood cell pulls in is the neutrophil, and then it pulls in monocytes convert to macrophages, and then that's the immune switch that flips, right? It's the macrophage immune switch that flips. If that happens, you get a healing cascade. And if it doesn't happen, you linger. And there have even been a few studies out there that have looked at the risk of chronic pain if you don't have an immune response, an immune stimulation response to injury. One was with acute back pain, one was with jaw pain and TMJ, even looked at fibromyalgia. If you have a flat immune response to injury, you tend to chronify. And so really the book, in some ways, it's kind of about the benefits of acute inflammation, for lack of a better term, and how that's kind of the backbone of regenerative medicine.
Awesome. So, a lot of my patients have been told, and we've all been told, you got to get rid of the inflammation, anti-inflammatories. Whatever you do, don't get inflamed. I got to get this inflammation down. And, as we go through this, it's like, no, let's harness this and let's ride that wave to resolution. Do you think that a lot of our reason why we have these chronic issues is because we've blunted our natural immune response with all of these anti-inflammatories, like everybody's living on ibuprofen? Do you think that in part that plays a part?
Yeah, I think it's a great question. And my suspicion is that we've probably accelerated the problem of osteoarthritis around the globe by soaking in anti-inflammatories continuously, because our bodies can't go through these cycles. The cycle of repair and recovery. We've blunted our immune system and it doesn't happen. And we need to kind of reignite it. And that's where, PRP and some of the other therapies come into play. It also explains, there's been a lot of great literature, and you've talked about this in your podcast as well, which is a great discussion of the importance of dose with PRP. And it also that's the same discussion. You've got to have that strong stimulus to flip the immune switch. And if your platelet count is too low, you're not going to get there. If your white count is too low, you're not going to get there. And I actually have a talk I've given before. It's called Don't Fear the Neutrophil, because we've also been programmed to think that all white blood cells, even in PRP, are not good for us. And that's just not true as well. Matter of fact, there was a study that Mark Parisian, Luda Diachenko, and others did up at McGill and with collaborators in Italy and US and everywhere else. And they were able to very clearly show that if you don't have neutrophil activation, you're more likely to get chronic back pain after an injury.
Okay. So now you've opened Pandora's box.
Yeah, so that I was hoping to open Pandora's box.
So are you telling me that this age-old adage of the fact that we want leukocyte poor PRP may not be true?
There is a clear role for neutrophils and white blood cells, not just monocytes and macrophages, but neutrophils in that healing cascade. And yes, that's what I'm saying, is I think we need white blood cells in PRP. It is part of the healing process. You can even go into laboratory research that's been done. If you have an animal that has their immune system blunted with steroids or NSAIDs, if you give them neutrophils, you can recapture the pain relief in those animals. You can flip that switch. And so we've kind of demonized the neutrophil in all of our therapies, but I am a big believer that you need that. It's part of that important immune stimulus to heal.
That is fascinating. I'm going to go one step deeper. Where do you, and this is our just question one, but where do you think we've gotten off track along the way, where we were like, get rid of the neutrophils. We can't ever have neutrophils, no white blood cells. Like how do we go so far astray?
When I kind of do a deeper dive into the literature, especially on PRP, it is, I think, understandable where this incredible confusion comes from, because there are so many products out there and there are so many formulations. And, again, you've talked about this as well. It's a really important conversation to say that if you've got 10 different PRP devices, you've got 10 different PRPs. And I don't know all of where it came from, although I've seen a couple of studies. I saw one meta-analysis that said you need to use leukocyte poor product for joints, but they also included some non-PRP studies in that, including ACS. autologous conditioned serum. So clearly that's going to bias you toward non-white blood cells because there are no cells at all in that. But I think that the data is increasingly clear. And I think it also stems from this fear of inflammation. We think that if we put white cells in, we're going to cause inflammation and it's going to do harm. And it's just not true. I remember seeing, it was a basic science study. They were looking at cell culture and they were talking about the harms of white blood cells in the PRP because it upregulated IL-1, it upregulated TNF and all these inflammatory factors. But what they also showed is when they did expression analysis, they looked at the proteins that those genes produced in those cells, it also turned on all these healing systems. And so to me, it's just like a workout. Regenerative therapy is kind of like a workout. You've got to suffer a little bit to get a good result at the end. And if you're not a little bit sore afterwards, it probably wasn't a good workout. And I think, should have the same philosophy with our orthobiologics as well.
Yeah, absolutely. That's such a fascinating topic. And I always feel like we're now at the beginning. Right? Now we finally gotten to the beginning. And before that was just all the preamble, right? So it's so fun. So for clinicians that are already doing PRP or orthobiologics for that matter, what do you think the most important sequencing change that they could make tomorrow? Like what piece of the puzzle do you think they're missing? Or maybe they've got it maybe backwards that you think needs to be clarified or talked about a little bit more?
Yeah, so for folks who are already offering orthobiologic therapies, right? The one thing I think is really easy to do is make sure everybody exercises before you pull their blood.
Okay. Tell me more
Yeah.
about that.
Well, one is
Make me a believer. Make me a case out of this.
yeah,
Why
well,
do
so
I put everybody on the bike for 20 minutes? Like, tell me why.
people have talked about platelet counts in exercise, and maybe there's some truth to that. But there have also been quite a few studies of growth factor release and exosome release, and all those other things that are in these orthobiologics that are produced and magnified with exercise. And so I think there are a lot of things in blood that we are not counting right now that we magnify with a little workout. So I think that's clear. A healthy diet. I'm a big believer in Mediterranean diet, so make sure, put your patients on a Mediterranean diet. There has been the discussion that come up, and I have this discussion a lot with patients as well, of turmeric and boswellia and some of the supplements before. I tend to have people come off those if they can. Now, the reality is if they're taking that and they can stay off their anti-inflammatory, then you leave it on it, right? Because it's better to be, I'd rather have them on turmeric than high doses of naproxen or meloxicam or something like that. But I always let people's immune systems kind of go wild a little bit. Turn it on, upregulate it, let it stimulate, and then 3 or 4 days later, after they start to see that immune switch, because if you look at that immune cascade and when you get macrophage polarization to that, this healing macrophages, it's a few days out, and so that's when I kind of restart some of those supplements. But I think those are very easy changes to make, and a good diet handout and a good thing to pay attention to for patients as well.
So, do you exercise every single one of your patients before you draw their blood?
I try to.
Okay.
Try to. What do you do?
I don't, and I should, right? I know the research, I know the science, and yet it's a all of us docs are really good about doing the thing we've always done. And so when you're like, shoot, man, I need a compelling reason why I should make this change, I know it to be true, and yet I still don't do it. So I got to figure out a workflow that works. Well, I don't have a bike in my office. Like maybe they can just go for a quick jaunt around. I don't know.
Yeah, and I don't have a bike either, but I just tell them to go for a brisk walk if they haven't worked out in the morning. You also don't want people coming in completely dehydrated either, right? So that's the downside. That's not good, obviously. But
Yeah.
but a light workout or a brisk walk around the block before you draw the blood, that's usually doable. Unless they're showing up late to your office, then it's a different issue, right?
Right. Yeah. Absolutely. Well, We still have some questions for you. So we're going to keep asking all of these really fun questions, but we're also going to leave some time for some question and answer time. So, what do you think are the highest yield diagnostic questions or exam findings that would point you more towards this like chronic pain, immune, nerve involvement rather than structural integrity or something to that effect? Like where are those aha moments where you're like, oh man, this we need an immunomodulator?
Yeah. So I wonder if you may do the same thing, but obviously, if you're looking at a joint, you're looking at stability of the joint, you're looking at if there's an effusion, that's easy. I tend to tap on the nerves around the joint too, because you end up seeing a lot of people with a lot of nerve sensitivity, even with, especially also with tendinopathies. And I tend to, add things. I'll do a D5 Prolo hydrodissection for folks if they've got a lot of nerve sensitivity around a joint. Because it does seem like, I don't know what you think, but it does seem like that it's kind of a whole joint issue and it's not necessarily just that medial compartment or just that labrum, but it's a whole joint. And when folks have a sensitization of the nerves, I tend to try to work on that as well. I'm also a big believer in, you're looking at the color on the ultrasound too. And if you're seeing, the usual hypervascularity and increased signal there, I tend to talk about things like adding protein concentrates and other ways to kind of cool things off a little bit for folks, help them flip that switch. What do you do?
Yeah, so I think that you're exactly right. And I absolutely really hone in on this concept of knee organ. Just it's a comprehensive environment, a microenvironment, and it includes the interarticular space. It also includes the extraarticular space. It includes the ligamentous status. And I do believe that it also includes the nerve status, right? I just had a patient today and she's like, oh, my meniscus is still hurting. And when she points, I'm like, okay, first of all, that's not your meniscus, and that's not even in the joint line, so it's not even close. But she's pointing to this PES location, and I
Right.
tell you, that
Right.
is so common. I'm sure everyone's like, oh, it's just PES bursitis. But then when you pop your ultrasound, there's no bursitis to be had. So then the question is it nerve? Is it one of your genicular nerves? Is it a saphenous nerve, neuritis? Is it a hamstring tendinopathy that is underappreciated, underrepresented? Like, I think there's more to the subject than a simple intraarticular injection. So
Yeah.
the likelihood that you are going to come to my clinic and get a simple intraarticular injection is basically zero, because I guarantee you I'm gonna find something else that's going on in the knee organ rather than just the simple intraarticular space.
Yeah, and your point of, PES tendinopathies is a really good one too. You probably had the experience, I had this experience of seeing this in a lot, especially the trochanter, right? People always talk about trochanter bursitis, and and years ago, we were dumping all kinds of steroids and everything else down there. And, I started looking about 15 years ago at those and realizing that most of these people that came in bursitis didn't have bursitis. They almost all had gluten tendinopathies. And if you get that to heal up, they do pretty well. If you dump steroid and they do great for a month and then they're back in 2 months to get more steroid.
Right? I think back to all the horrendous things I've done to my patients over the years just because I didn't know any better. I used to have this protocol for, lateral hip pain, bursitis, right? Where I would do a blind steroid injection. And then if they didn't get better, then I would send them to therapy. And then if they didn't get better, I would MRI. What I noticed is nobody had bursitis, right? It was all gluten tendinopathy.
Yeah.
But
Yeah.
yeah, I still didn't appreciate that until I read Jane Fitzpatrick's study, and it was like, use PRP, dummy. I was like, oh my, this is interesting. But no, it was even before that, there was a lot of conversation in the orthopedic literature about the fact that the lateral trochanteric pain was like the rotator cuff of the hip, and that we had a lot of tendinopathy that was not appreciated, but we still didn't really understand that biologic component of it, and we were still dumping steroids in it for a long time. I think Jane Fitzpatrick's follow-up study that showed the in my opinion, the detriment that is the cortisone injection, right? So when you look at her follow-up study at 5 years, at least 50% treated with PRP healed completely, no evidence of disease. And in the 50% that didn't heal, they had all had previous exposure to steroid. So I think if you're exposing your patient to steroid, you are condemning them to worse results because they don't have that ability to heal. Even when you have subsequent exposure to PRP, right? It's devastating to think. You're like, oh my gosh, what have I done to all my patients?
Yeah, but we didn't know any better. 15, 20 years ago, we were all doing. That's what, we didn't know it. And it really wasn't until we all started looking and
Yeah.
looking at the structures of the tendons and looking at the fact there really wasn't bursitis in most people. And if there was, it was always associated with a tendinopathy, and starting to think, then you think, how do we get the tendons healthier, right? And the answer is really going to be growth factors and PRP and things like that. So it was
You mean
really interesting, right?
don't dump steroids in it? That's weird.
People felt a whole lot better, but it was really an interesting time because I think a whole lot of us all came to the same conclusion nearly at the same time, and from a lot of different areas. But it makes sense, right? And also, again, makes sense with this concept of immune stimulation and good inflammation, that we need this to heal. And to me, osteoarthritis and tendinopathies are just chronic wounds. You don't treat a chronic wound with steroid. You treat a chronic wound with things that promote healing of the wound, right? And it's not a big surprise that the first PRP publication ever done was by a wound surgeon. It was Dr. Knighton in Minnesota. It was 1986. He was to heal wounds.
Yeah.
Makes sense, right?
Yeah. So we still have more questions. This is so great. I mean, honestly, I read your book in one day. It was phenomenal. I loved it. And I was like, I think I called you the next day and I was like, oh my God, this is amazing. So for practical interventions, what do you think is the most practical, low barrier intervention that physicians who maybe aren't practicing, having a lot of PRP in the orthobiologics in the clinic, what do you think is the easiest framework, the easiest way to kind of talk about this need for acute inflammation, for immune stimulation?
It's hard, right? Because patients come in and they want to fix, and they're used to taking anti-inflammatories when they hurt. I wonder if education, and I know education is very time consuming, which is actually one of the reasons why I wrote the book, so I could give the book to patients and say, please read chapters 10, 11, 12, or chapters 4, 5, 6, or whatever it is.
Brilliant.
And it's really been nice because then I can start a conversation with them, and then I can use the book to kind of finish it. And I said, so we started this, but I really want you to do a deeper dive in it, because they come in with fantastic questions, right? And even if you have a longer clinic appointment, which fortunate to have longer appointments, we still run out of time because it would take 9 hours to do a full explanation of what's going on, right? And
That's not cost effective. You are correct.
Right. And so to me, the book is a teaching tool. So I have handouts. I have handouts I use on healthy foods and fats. I try not to use the word diet because diet is a triggering word for many people. So I talk about healthy foods and healthy fats. I have handouts on exercise. I also do employ and look at some supplements. We've mentioned a couple of them before. To me, the strongest argument for them is if I can use them to decrease the need of the use of anti-inflammatories chronically. So to me, it's the educational tools and those handouts, and then also the book has been, at least for me, a really valuable educational resource as well, especially for patients who have an interest in exercise, healing, want to get off medications, interest in PRP or stem cells or ACS or any of the other therapies, that they can go as deep as they want into it. Because this, I think the science is, I worked really hard. I mean, it took me over 6 years to write the thing. So I worked really hard trying to make sure the science was accurate but understandable. And I had an editor who kept on me to make it understandable because there are lots of parts that we had to chop out for simplicity's sake. But in the end, I think and I hope it works for the lay reader as well. So.
So yeah, it's really interesting because the way that you wrote the book was understandable to the lay reader, but what I really appreciated is that you didn't dumb it down. And so as a physician getting into orthobiologics, really looking for that scientific basis and background, it's absolutely what I would consider a must read primer for anybody that's getting into orthobiologics who hasn't really had the exposure or the ability to deep dive. I wish I would have had this early on in my career when I was getting into it, because let's face it, orthopedic surgeons are not well versed in the orthobiologic world. We spend a lot of time talking about surgery and widgets and then like how best to construct X, Y, or Z. But I think sometimes we forget that there is a biologic human attached to all the cool things that we can do. And so this was such a thoughtful, well-versed scientific primer that is clear enough for the layperson, maybe not fifth grade level, but I think that clear enough to really help, but also smart enough and deep enough to work an amazing magic for docs as well. So thanks so much for that. I mean, that's a labor of love for sure. I do have kind of a question, and I would love if you could walk us through, this consideration of immune plus nerve, and like, before you had this framework of thinking about nerves, thinking about immune stimulation, thinking about maybe central sensitization, chronic pain, back in the day, that 15 years ago you versus the today you, where do you treat cases differently besides clearly the trochanteric bursa problem? What other cases have you kind of done a 180 with? If you could explain it to us, maybe an example of that.
Beyond what we've already talked about, I guess I could use myself as a case study as well, because I've had a couple of knee injuries, and I had one about 15 years ago, and I had another one a few years ago. And the first one, I stuck myself in anti-inflammatories. It was a slow recovery. It was a meniscus tear. It was a basketball game gone bad, a meniscus tear, and I didn't have surgery. But it took me about 6 months before I was really back to function. And the second time around, I actually had a bigger injury, and I ended up just letting it flare. I didn't take any anti-inflammatories. I had colleagues that thought I was insane because I was limping around for a couple of weeks. But I was skiing again a month later, so it wasn't a 6 month recovery. It was a month, and I was still a little discomfort. Certainly, it was nothing compared to what Lindsey Vonn has gone through recently. But it was a nice comparison of what happens if you suppress the inflammation to just let it run, let it convert, let the immune cells and immune stimulation occur, and work through that. And it was a little bit of a individual, I guess, an N of one experiment, for lack of a better term. But it was a nice illustration that, again, it hurts to have a tear and to not take anti-inflammatories. But the recovery was faster, and I think it was a nice lesson for me as a little bit of a proof of concept in some ways too. And so I use that example with patients as well, because they come in with issues and injuries and things, and so we can talk through that, and that's helpful because it doesn't come across as me preaching to them, because I've kind of gone through it myself, and so that's an easier, it's neat. I think it feels like maybe an easier conversation in some respects, because I'm just not telling them, you need to hurt, you need to be off your anti-inflammatories. I said, I can tell them it does hurt. It's, but you're going to heal faster because your body's going to do a lot of the work for you.
Yeah, yeah. I mean, I also share my experience with, PRP. Definitely, I've had simple intra-articular injections. I've had my most amazing claim to fame is I had a full tear of my collateral ligament on my index finger. And as a surgeon, that's kind of annoying, right? Where every time you go to use it, it's
More than annoying.
yeah, it's very annoying. And I was like, gosh darn this thing, this is not healing. And so I finally put an ultrasound on after 6 months of ignoring it. and it was fully torn. I was like, well, shoot, man, this
Wow.
is the
Yeah.
problem. And I went and talked to the surgeon, and he's like, well, we can probably, repair this, and you'll probably get back to work by like 6 to 12 weeks. I was like, probably, first of all. And second of all, 6 to 12 weeks? That's a problem. That ain't happening. So I got this brilliant idea that I was gonna just inject my ligament and the joint and brace it and see how it went, right? Holy smokes, it hurt like the dickens. I couldn't even put my hand below my heart for like 2 days. And then I poorly planned as well because I had surgery like 2 days after a PRP injection, which is idiotic. But I will say that I was able to work and operate with a brace on, that whole time period. And then the star of the story is I had complete healing of a
That's amazing.
fully torn collateral ligament that had been torn for 6 months, right? Because I'm an idiot.
Yeah,
So
that's remarkable, really.
it
Right?
really is remarkable. And so, the consideration is like, can this stuff actually work? And clearly I am a connoisseur, but I also have seen it work for me for those exact reasons that all of our patients come to see us because they don't want surgery. They can't take time off, like 6 to 12 weeks off. Oh, sure, because I'm independently wealthy, of course, you know? And so I think that's a consideration that we all have to put ourselves in our patients' shoes. And we tell patients a lot of weird things that we would never accept for ourselves. So I would agree that N of one is a pretty interesting experience.
It is, and it brings it home a little bit too, right? I kind of consider myself a specialist in orthopedic limbo, and those are the folks I love seeing, right? It's the patients who they can't do what they want to do. They still got a lot of cartilage left. They're not a candidate for joint replacement surgery, or they're too young, but they can't do what they want to do, and you try to get them moving again. Because we all know, movement is key, right? So if we can get them back to the gym, and it does them a lot of good. We could also talk about some of the misconceptions around, the concept of a stem cell versus a mesenchymal cell versus
Oh
how they
boy.
work as well. That's another Pandora's box if you want to open that one up.
Yeah, yeah. So I think where I would like to go is like, and maybe clinician misconception, but maybe, referring physician where they want to refer your patient for this stem cell injection, right? Oh, can't you just fix their pain with an injection? I want my pain shot, right? So how do you communicate to clinicians what it is that we are actually doing? Are we using stem cells? Are we not using stem cells? Or like from a clear perception that maybe you used your book to kind of clarify this, but also is helpful for the non-orthopedic physician who may be wanting to refer to you. How do you kind of clarify this for the layperson but also for the referring practitioners?
I think we're just finding ways to stimulate everybody's own healing response. And I feel like, humans, we have built-in healing systems. Sometimes they get a little tired, a little worn out. And my job is to kind of get them stimulated and get them turned on again. And so that's what I do. And when we can do that, sometimes it's nutrition, it's exercise, and maybe it's prolotherapy, maybe it's PRP, maybe it's some of the other more advanced therapies. But all these are doing are turning on everybody's innate healing mechanisms. And so that's what I tell people we're working on. And I don't tell people we're not growing new tissues or growing new cells. I feel like I tell them we're making tissues healthier, and we're making function better. So.
Yeah, and so to that end, there's always this conversation about, is it really regenerative medicine? Are we really regenerating cartilage? Are we really regenerating tendon? And I think, and you tell me if this is partially correct, is in part I think we are making tissues healthier. So are we growing new cartilage? No-ish, but we're not fully wrong. So can we comfortably call this regenerative medicine?
If you define regenerative as improving tissue health, then yes, right? We're not growing new ears or growing new kidneys in a lab culture, right? I mean, that's a different world.
Not
We're
yet.
not using inducible pluripotent stem cells or some of the other things that people do, but we're improving tissue health. And so that's where I like to leave things with patients is that we have very good tools to do that. And with that comes pain relief, very often. And sometimes it obviously takes a couple weeks for the pain relief to kick in, but that's how I like to present it to patients. You're right. I mean, you do recruit, so even if the cells or the tissues or the what you're injecting isn't growing and new cells long term, you are recruiting, the body's own regenerative cells to the area via those chemotactic signals. But that's a little bit of a different argument, isn't it? But it's still restoring tissue. It's restoring
Yeah.
tissue health.
Yeah. Yeah, I would agree. And if you are completely healing a tendon or a ligament, isn't that regenerative?
To me, it would be
So, yeah, I
you.
don't know. Like, I think the jury's still out on that. And I think it's also semantics. But for the most part, I feel confident and comfortable to consider this as a regenerative therapy. I think we're not wrong. So, thanks so much for sharing. The question is always, okay, so we've done this massive deep dive on science. So, what does that next step look like? Well, clearly, we want to be able to now take this science that we're used and we've done the deep dive on and say, okay, now that we have a really clear understanding of the science, how do we use this knowledge to help the right patients, the ones who need our help? And so our practice launch system is part of the way that we define, and I think you've had a little bit of exposure to this, but our orthobiologic practice launch system helps you with the orthobiologic knowledge, how to attract the right patients, how to create a viable cash-based business, how to have high converting consultations, and then clearly putting it all together for success. If you want the fast track, I'm going to invite you all to Clearwater, Florida for our hands-on workshop and lab, the Business of Orthobiologics Express course. This is a Saturday afternoon 4-hour course about patient-focused branding, how to keep your orthobiologic patients from your practice and treat them, effective pricing strategies, how to use AI to expand your practice with tools and tactics for growth, proven solutions to overcome challenges and avoid the pitfalls that are common in cash-based practices. And then on Sunday, we have a lab about that we talk and teach lipoaspirate training for MFAT. This is a cadaver lab. We also review bone marrow harvest and concentration, as well as getting your hands dirty for PRP and protein concentration processing. This is hosted by Apex Biologics, and the best part is there's no cost to attend. So if this is interesting, these are the dates for February, March, and April. Just scan that QR code and take a look. If you are wondering what your next step should be for your orthobiologic practice, whether you're just thinking about it, in the middle of it, or wondering how you can scale and grow that practice, if you want to take a little quiz that we've put together, just scan this QR code and there's just a little quick quiz and it can give you some guidance as to your next best step. Finally, the book we've all been hearing about. This is Dr. Buchheit's book. It is wonderfully amazing. I love it. I do truly think this is a primer that everyone who's doing orthobiologics should be reading. The QR code is there. Please scan that QR code. If you can't find it, just search Healing Joints and Nerves by Dr. Thomas Buchheit. And we will, it's on Amazon. Go get it. It is definitely a really great book. So kudos to you. I think what we'll do is take some questions. Dr. Buchheit, thank you so much for joining us. It's been an amazing conversation. If anyone has any questions, please put those in the chat. I'd love to hear. And then we'll go ahead. I think we may have a Q&A, but I can't remember how to
And as
find
you're
it.
doing that, I'll put a plug in. Your course was great, Ariana. It was a great course. So,
Oh, thanks. Yeah, this one.
yes.
Yeah, it's so fun. It's a quick 4-hour course about the top ways to become successful in cash-based business, right? And we never learn this stuff. We don't know this stuff. But what we have proven is we are physicians that know how to learn. So this is a teachable, learnable skill. It's just what we haven't gone to school to do this yet. So come to this express course. We'll go to school for a little bit and understand how we can best serve our patients with orthobiologics. I do have a question here. There's a question about the natural anti-inflammatories like turmeric. Do you think it blunts that response? Or do you think it's an actual natural anti-inflammatory? Like, I actually don't know. I use turmeric as one of my supplements that I use to get patients off of ibuprofen, Aleve, any of those things. I add turmeric, I use fish oil, I use, the berberine to make sure their blood sugar is stabilized. I use a number of supplements to really kind of enhance their overall health and well-being, to be able to, and I tell them, listen, you're the pharmacy. I gotta borrow from the best pharmacy. We want the best pharmacy possible. So we're gonna try to optimize your health and your cellular metabolism so that we can get the best things out of it. What's your thoughts on these supplements blunting that natural response?
I do think they probably blunted some. Again, I think if you're choosing between an anti-inflammatory over the counter versus a turmeric and boswellia or whatever combination you want to use, clearly there's significant benefits of the herbal versus the pharmaceutical in terms of gut health, in terms of kidney health, in terms of all the side effects that you're avoiding. But these herbals, turmeric in particular, I believe, is an NF-kappa B inhibitor, similar to some of the other ones, right? And so there probably is some inhibition of that immune stimulation signal. And so if somebody is on it and they're getting great benefit of it, I'm careful of taking off, but I still tend to take it down a couple notches or even off prior to blood draw, for instance, for PRP. I'm not sure if it's as important as taking them off their ibuprofen or naproxen, but it's one more thing that I think can blunt that immune cycle a little bit. So
Yeah, I think that's interesting that you bring that up, and I think that that's not, it does. I was just looking it up, and you're exactly right. It's the NF kappa, and so now I'm like rethinking everything I'm doing here, and I'm like, oh man, I don't know. But yeah, what's the lesser of two evils? I think we've shown that ibuprofen and Aleve are less beneficial, but I think that's a great question. So I think the answer is that if you can be off everything, that's the best.
I
And
think I think that's
your
the
body,
answer. If you can be off everything, that's the best. Let your body do the work, and then go back on it after 3 or 4 days, or even 4 or 5 days of macrophage polarization, and then get back on them. I think that's the
awesome,
ideal.
awesome. Okay, so now no one else is wanting to give me any questions, and that's totally fine. I have you all to myself, so this is perfect. Now, in the book, you talk a little bit about the autologous conditioned plasma. And for those of you who are not like, what is this? What is this deal? Like, tell me a little bit about your experience with this, and maybe where things are going from this standpoint.
Well, I had a little bit of an interest in it because autologous conditioned serum it's been out for a while, and I was working with Peter Whaling and some other folks in Germany from clinically and from a research perspective. People call it IRAP, and if you even go to the veterinary circles, they call it IRAP, which stands for interleukin-1 receptor antagonist protein, so IL-1RA. And everybody thought it worked because it shut down IL-1, and IL-1 we know will chew up cartilage in a joint, right? So IL-1 chronically is pretty damaging to cartilage. And everybody thought, well, this process, that an incubation process, it releases IL-1RA, it blocks IL-1, end of story. But it wasn't the end of the story, because there's a recombinant protein out there, anakinra, that, rheumatologists use, and that was tried in osteoarthritis and it didn't work. As a matter of fact, by the way, as a side note, if we look at all the trials that have been done for immune suppression and osteoarthritis, they've all failed. Tanacercept, a TNF inhibitor, failed. Adalimumab, a TNF inhibitor, failed. IL-6 inhibitor failed. And IL-1 inhibitor failed. They all failed, which again backs to the story of suppressing inflammation doesn't cure osteoarthritis. It's a wound you need to heal, not inflammation that you need to just shut down. But there was the same process with the autologous conditioned serum that we were looking at. So we started doing a deeper dive and just looking at it in the lab. And it turns out that actually a lot of it's driven by exosomes. We were able to show that. You pull them out, it stops working, it takes away most of the effect. You put them back in, puts the effectiveness back in.
And these are autologous exosomes.
Autologous exosomes.
Yeah.
So, and it's going to be really interesting to see how the exosome story evolves over the next few years. They've been a little bit tricky, right? Because a lot of them are manufactured off of cultured mesenchymal cells, and obviously culturing mesenchymal cells is not considered minimum manipulation in the United States, and so that gets very tricky. But I think the story is not going away. The possibility for exosome-based therapies is going to be interesting, and I think if you look 5 years ahead, there's going to be something out there.
Yeah. Now you said something, and I really had a question about that because you're right. They've tried to treat osteoarthritis with all of these immune inhibitors. Now, there are some very interesting things happening with the GLP-1 medications that are showing significant improvement in osteoarthritis symptoms. And so it just dawned on me. I'm like, okay, well, that was a definite, oh, by the way, wow, this is cool. We found an arthritis treatment.
Yeah.
What do you make of that?
Well, so do you think that's because of the decrease in severity of metabolic syndrome and the folks who are on GLP-1s?
I no.
You don't think so? Yeah.
I don't
I
think
was
that's
thinking,
the main issue. And I'll tell you my experience about the GLP-1s and what I've noticed over the years in my patients with these inflammatory arthritis. They happen really quickly, right? So their symptoms start to resolve quite quickly.
Before reversal of the metabolic syndrome.
Yeah. So
Yeah.
case in point, today, I have a patient, we started on GLP-1s 1 week ago. She has significant improvement in her pain function. Nothing else changed. She lost 2 pounds. She's greater than 300 pounds.
Wow.
Metabolic syndrome is massively problematic. Did we change all of her hemoglobin A1C? Did we change all of her cholesterol? Did we change all of her metabolic syndrome? Good God, no.
What do you think's driving that effect?
It's really interesting. The first time I heard anything about this, I went to the Peptide World Conference, right? I'm like, ooh, great. I'm gonna learn all about peptides. This is gonna be great. And what 70-80% of it was like diet, exercise, sleep, stress. And then, oh yeah, by the way, there's this peptides. And the most famous peptide is a GLP-1. And what I came away from that conference was showing that this peptide on all the main metabolic cellular health pathways was beneficial. So I think it is actually positively affecting your cellular health much quicker. And that's why we're starting to see this like almost miraculous decrease in arthritis symptoms pretty quickly, is because we're starting to affect the cellular health pathways at that base level quicker than you can affect the metabolic syndrome.
Yeah, so it's going to be really interesting to see how that story plays out. Somebody's got to do a study on it. Maybe they can do a study in tendinopathies as well.
Yeah. There's so much there. I mean, right. We just started the beginning, right?
Right. Yeah, I know, and I think you're right. That's a really important point, is that this is the very beginning. It's a new field of medicine. It's a new field of science. We know so much more now than we did when I started the book almost 7 years ago now. There were so many questions, and some of those questions have been solidified. Even the simple questions of platelet dosing. I mean, that's so nice to have that information now. The importance of immune stimulation, the importance of white blood cells to stimulate this healing response has been clarified quite a bit with some really important high-level publications as well. And so the story is clarifying, but they're still evolving, and I think it's a really exciting time.
Yeah.
I think in 10 years, we're going to look back and say, I can't believe we were doing all those steroid injections and doing all those anti-inflammatories.
Oh my goodness, right?
Yeah.
Like literally, I think back and I'm like, oh my gosh, what was I doing? How could I have like injected cortisone in people's hips and been like shocked that they needed a hip replacement 6 months later, right? Like, I realized we didn't know that then, but at the same time, it proved true in my own practice and then was later borne out in the literature. And so I rarely use steroids. I use them so sparingly that it's like it goes bad in my cabinet, right? Because I just don't use it. There's so many other options. There's so many good things. There's prolotherapy, there's neuroprolo, there's, even Toradol intraarticularly, there's PRP, BMC, adipose, protein concentrate, ACS. Like there's so many things. Why reach for a steroid?
Right. We've got a lot of tools now that we didn't have a while
Right.
back, and it's really an exciting time.
Awesome. Awesome. Well, thank you. Oh, Deep T Agrawal just shared a graphic that illustrates the GLP power. Awesome.
Yeah, I just shared it with you. Hi, how are you?
I'm
It's
good.
a nice graphic. I love showing it to patients that come in, and it's like, first you want to rein in your metabolic health and make your terrain nice, and then you can add all these regenerative therapies and things work so much more effectively. But it's hard for people to understand like their arthritic conditions and how that relates in the bigger picture. So I love that graphic is very simple for patients to look at.
Yes, yes. Yeah, basically, these GLP-1s are inhibiting that chronic inflammatory state. And so going back to acute inflammation is good, chronic inflammation, do you think, Deep T, do you think that it resolves that chronic inflammation, or do you think that it blunts the effects? Like what do you think the GLPs are helping to kind of
Yeah,
resolve
I
the
think it's
issues?
really dampening that metabolic cascade of inflammation. So that microenvironment is helped. So when you put any sort of regenerative therapy on top of it, the appropriate inflammatory response takes place, but you've mopped up what you can before you do that, right? So it's just more effective.
Yeah, yeah. I think this medication, has been helpful for my patients, helpful for primary treatment of arthritis. For some of my patients, this is all I'm doing for them for their
Yeah.
arthritis.
I've solved a lot of chronic pain issues just with metabolic management, and that I'm like, hey, maybe you should now think of something regenerative for that congenital hip dysplasia because it will bother you at some point.
Yeah,
But at
yeah,
least
awesome.
harm reduced. And so now you're doing things in a really nice stepwise manner.
So
Now,
good. Thank you
when I
so
think
much
of
for
it,
sharing that. That's so
Yeah.
great.
yeah.
Gosh, I love this conversation. Thanks,
Yeah,
guys.
me too. Me too. Thanks, Tom. Nice to meet you. I'm so
Oh
glad.
yeah, great to meet you. Thank you.
I'm glad someone in anesthesia is thinking this way.
Welcome, the both of you. 1, 2, ready, break. No, we've got a bunch of
We got
people.
some work to do, but you've done so much, Ariana, for the field, so that's great.
Thanks, guys. Well, we are over time, but again, this is the book. This is the primer you should be getting. If you don't have it, please go to Amazon. No, I don't get any kickbacks from it. I just think it's an amazing book. So please grab it. I think it will be one of those books where you read it and you go, oh man, this makes so much sense. So, Dr. Buchheit, thanks so much for joining me. Thanks for taking 6 years to write this amazing book. And for everybody else, thank you so much for joining us. We'll see you back in 2 weeks. Look forward to another amazing conversation, and I am looking forward. Next, in 2 weeks, we have Dr. Kristen Oliver from the Blue Tail Medical Group joining us. So please, please, please come back, hang out with us. We love to have all of this conversation. Have a great night, everybody, and we'll see you in 2 weeks.